To RSI Help YouTube. I'm Deborah Quilter. And one of the most common experiences people have with RSI is that they've gone to nearly a dozen doctors before they finally find someone who can accurately diagnose and treat them. And this is important because the window of time where a proper diagnosis and treatment can really turn things around is very short. So if you keep going on with your life without an accurate diagnosis and good guidance and good treatment, you can wind up with a chronic injury that takes a long time to get better. Here to tell us some common misdiagnoses that people experience with RSI is our Chief Medical Advisor, Dr. Robert Markison. He has nearly 40 years of experience as a hand surgeon and is a clinical professor of surgery at the University of California, San Francisco. So welcome to the show.
Thank you. Great to be with you again. And I'm very glad for our long-term acquaintance and working together. And we have no financial attachment, but it's been very positive. I was circa 1992. We were in New York City talking about repetitive strain injury. And I think some eyes opened and minds brightened up. And here you are. You're a leading light.
What do you see in terms of, I bet people come to you after they've seen other people.
They do. That's true. Often. I mean, some of the problem is myopia, and if you've got a hammer, the world's a nail. And so, for example, the patients referred by physicians with quote carpal tunnel syndrome have not had a proper cervical spine exam, brachial plexus exam of any other potential peripheral nerve entrapment within the big three, which is median, the carpal tunnel nerve, can be entrapped other places, not just here, but also cubital tunnel, the funny bone nerve, going there, radial tunnel, the one on top. And so failure to have a complete exam, either by the primary care referring physician, lack of self-exam or awareness, and then even seeing a specialist not having a complete exam. These are time-consuming things. So incompleteness of examination with myopia, the whole world looks like carpal tunnel, where it may not be carpal tunnel at all.
You bring up 2 points that I think are important. I've always heard that RSI really starts in the neck, which makes sense because so many people have a forward head posture. And the other thing, we were talking earlier about how long it really takes. It could be an hour and 15 minutes to get a thorough, complete picture of a patient.
It's all true. And again, you're looking not only for normal anatomy that may be troubled, but you're also, if you're a good student, so to speak, considering that there are myriad anatomical variations of the upper extremity, which is tendons, nerves, bones, joints, vascular supply. And so you're not only thinking what is normal and the expectation, but most anatomically varied body system is brain and neck to fingertips and back. So you have to, chance will favor your prepared mind if you really do study, and I mean study, anatomical variation, because it's not the same in a given person, side to side or person to person.
Yes, and for the viewers out there, we're going to have Dr. Markison back on the show talking about anatomical variations, which is a whole separate issue, and it's very pertinent to RSI because that's why two people doing the same job don't necessarily have an injury or experience it the same way. One person might get injured, the other one may not, and it could be due to just what Dr. Markison was saying. So one of the things that I saw when I was sitting next to the doctor who was doing examinations, I heard a lot of people say, you know, I've had a carpal tunnel release, but they didn't even test for carpal tunnel, and what was actually going on was de Quervain's disease. So I'm sure you've seen that yourself. Can you talk?
Right, misdiagnoses and even surgical misadventures. And I'm not the arbiter of ultimate medical surgical good taste, but if anything, I've got a very functional level of obsessive compulsive disorder where the screens and filters, cognitive and examination, must be really pretty tight to look for anything and everything. So we've talked about the main pitfall of inadequate complete examination, but we must remember that physical examination is a big deal, but total history taking And when you fail to take a total history, again, time consuming, and I don't mean just a checklist on an electronic health record, but what do they eat? What drugs do they take? Do they exercise? If so, is it excessive? Is there family history of same things? Endocrine history, prediabetes, diabetes, thyroid disease, other endocrinopathy, gut integrity, gut happiness, gut sadness, because 90% of happy hormone, which is serotonin, is made in the intestines. And if you overexercise, for example, and you think you can run away from the plague, then you're shunning blood away from the gut, which is not only making happy hormone, it's also processing a fair amount of T cell immunity. So you could run yourself into the ground and rob yourself of gut, brain, body integrity. And so these are things, total scope of self-use, food, because the great Hippocrates lived, what, 460 to 375 BC on the Isle of Kos, a beautiful island where he had a genius who said, food is fuel, food is medicine. That's Hippocrates for you, way in advance of our technology. And so a total history, failure to get a really great, solid history of the now and the past is going to lead you down some rabbit holes and blind alleys.
And so let's take the endocrine system because you brought it up. So what could happen? Someone goes and they're misdiagnosed. So how could their misdiagnosis manifest? What sorts of rabbit holes could people go down?
Well, hypothyroidism is surprisingly common. So for example, if you have not been blood tested for it, and yet you have multifocal aches and pains, maybe some fatigue, cold hands, cold feet, swings in blood pressure, mood changes, fullness in the throat. These myriad signs and symptoms of subtle or obvious hypothyroidism are ironed out by having a blood panel for thyroid, which is T3, T4, free T4, TSH, and TPO, which is anti-thyroid antibodies. And you want to know that. And I agree with the American Society of Clinical Endocrinologists, published November 2002, that you want to have your TSH, thyroid stimulating hormone, AKA thyrotropin, in between 1.0 and 2.0, preferably closer to 1. So on the thyroid score alone, there are so many ways that hypothyroidism can present, including snoring/obstructive sleep apnea, that you want to know about the thyroid gland. It's a wonderful master gland.
Well, what about doctors who may be dismissing RSI because they don't understand what you understand so well, the relationship between tool design and endless hours of work and soft tissue injuries. So someone comes in with thumb pain and they're given a prescription for a non-steroidal anti-inflammatory or something and dismissed without looking at all these other aspects that could be coming into play.
Right, so then again, it's the history of total scope of self-use and hand use. And for example, if we're an artist and we're looking at a contour line going this way, and we decide to go up and down on a space bar, you can see the distortion of that joint. So you'd actually want to watch the patient typing. And everybody's got a computer in the office nowadays, and you watch how they type and whether it's noisy, percussive, whether they do have, as we were talking earlier, dependent, because my ring and little were born pretty much together, or independent function, and whether they're slamming away at perimeter keys and the whole thing is just too noisy. You'd really want to watch how they use things, and that bears also on anatomical variation and asymmetry. But again, you want to know what their ergonomic setup is, and since the world of work is shifting towards remote, home-based, often where you're involved in child care or pet care or other things, or care of elders in addition to the increasing load of single-tasking hands-on computing, you'd like to know what their setup is: a sit-stand workstation, a proper seating arrangement, breaks, cycles of action and repose. So there's a lot to take in there, but you certainly don't want to give them a raft of potentially gut-impairing anti-inflammatories. And then you add misery by giving them a acid blocker so they'll, quote, tolerate it better. And then that results in single and multiple vitamin and trace element malabsorption. So you've created an iatrogenic vicious cycle by failure to really countenance and observe and think about the total scope and methods of body use.
So, Dr. Markison, what are the 3 top misdiagnoses you've seen in patients that have come from elsewhere?
I think carpal tunnel syndrome, a wastebasket term, tendonitis or tenosynovitis. And obviously you want an anatomy-specific diagnosis to properly drive treatment. And so it's failure to make an anatomical diagnosis. And I guess the third one would be, again, failure to understand that it might be pain, aches and pains caused by something that is not quantifiably, physically, clinically present, but is nonetheless very painful. And so that's the misdiagnosis based on unrecognized endocrine, metabolic, drug-related, food-related things, leaky gut syndrome and all that kind of stuff.
So if you're coming in, I've been a consumer advocate for many years. So if you're coming in as a medical consumer, and this is not to judge the doctors or second guess them, but are there any red flags that would tell someone, because we trust doctors, we rely on doctors to diagnose us, to steer us in the right direction. I have been helped by so many doctors myself. I worship my own team. But sometimes doctors are not equally educated. So what are some of the red flags that you might look out for to think, gee, maybe I ought to get a second opinion about this?
Well, it's fair to ask a doctor if he or she is interested in the problem of repetitive strain injury, or whether they discount it as fantasy and the imaginings of an unhappy worker who wants out. And so if a doctor is fundamentally not interested in it, doctors have their own hobbies and interest areas, then maybe seek a little additional opinion. Plus, as you know, we have a lot of well-intended frontliners now, medical assistants, physicians, assistant nurse practitioners, all of whom may be very good, but maybe gathering the whole history and doing the physical exam, and then the doctor comes in for a minute or two and rubber stamps it and says, yeah, that's good, give them some Motrin. And so you want to have somebody who takes the time and has a hunger and thirst for just knowing holistically and very specifically what the trouble is and what a reasonable course of treatment would be. It's fair to ask a doctor if they're interested. Look, frankly, I'm not doing trauma hand anymore. I've trained enough surgeons who do it well. Why shouldn't they do it? If there's a reconstructive problem later, I might be on the phone or even in the OR with them, which is fine. But there are certain things I'm not interested in very much anymore. And I face it, and I'm happy to tell patients that.
Well, on this note, I just think from your lips to God's ears, what great advice. You know, it's always so refreshing. So thank you for coming on the show, Dr. Markison. And thank you all for watching. And please stay tuned. We're going to have more with Dr. Markison soon.
Great. Thank you.